We've been talking a lot today about sustainability issues. We've talked a lot about some of the real challenges we see. We're now going to hear a little bit about solutions and about ways that we can attack this problem from various innovative angles, both at individual levels, at the scale of institutions, and at the scale of legislation and healthcare policy. So our first session is from Megan and Stella. They are fourth-year medical students at Indiana University School of Medicine. They work in the medical school, has been centered around climate action and advocacy in the medical school curriculum. And they're going to be sharing some lessons for us on working to get climate change and health content integrated into the medical school curriculum.
Well, thank you so much, Kayla, for that introduction. And it's exciting to hear what our friends abroad have nationally implemented climate change education in their curriculum. Unfortunately, in the US, we're not so on top of that yet, but we'll give an example of what we did at our institution. So Indiana University School of Medicine in the Midwest is actually the largest allopathic medical school in the country. We have 364 students per class, but we're divided up across 9 regional campuses around the state. So there's a variety of urban and rural locations. As a state medical school, 83% of our students are from Indiana, and there's a large focus within the institution on training physicians who will continue to practice in Indiana. And as this is not a state known for having very progressive climate policies, it's a huge opportunity to train leaders that will be active in their local communities if we can incorporate climate education into our schooling.
So this is a slide just demonstrating, it's by Dr. Hampshire, who I believe is here today, but in one of the breakout sessions. And it kind of demonstrates the gap between interest of medical students and the perceived importance that medical students feel about climate health and its integration into the curriculum versus how students feel it is successfully taught in schools and how it prepares them for clinical practice going forward. You can see the difference, 84% versus 6.3%. And so that is similar to how we felt going into medical school. And with that feeling and this knowledge, we incorporated the Planetary Health Report Card, which was developed by 4 medical students at UCSF. And has been growing nationally and internationally since 2019. We began it in 2020 and created it as completed it as a needs assessment in order to identify the gaps at IU and what we can personally do as an institution and on the individual level in incorporating planetary health and sustainability right at home.
As you can see, we got a D+, so that was not ideal. Lots of room for growth. So yes, there's some more statistics there, but some of the issues that we decided to address or highlight was curriculum. The only places we got points towards the curriculum was that we had a pretty robust social determinants of health curriculum throughout, longitudinally incorporated throughout all of our education. Just no one had made any explicit links between climate change and how that is a social determinant of health that's affecting patients. Additionally, for research, we do not have any faculty who are conducting research in this space, but we did have a lot of resources that could be available through our School of Public Health at IU, Office of Sustainability. We have some strong players in Indiana, but there was no connection with the medical school. And so overall, we were just very decentralized. Everyone felt like they were acting individually. People didn't realize that there were other people that cared about these issues. And we personally decided to look at education. We had varied interests in, one of our group had a master's in education, master's of public health. We felt like this was an area we could tackle. And this is an example of our phase 1 curriculum, which is basically our preclinical years. We have 9 courses that we take separately. and they kind of go through all of the body systems. And so one main way we wanted to approach adding climate education into our school was to incorporate it into every single one of these phase 1 classes, as the body systems method lends itself to also teaching about how climate change is impacting health in those body systems. We, after speaking with Dr. Phillipsborn, she highlighted the importance of, after laying that groundwork that every single student will get, having a dedicated climate health elective for the most passionate students to self-select into, and really use that as a place to build skills around advocacy and becoming leaders in your community and communicating climate health information, as we were hearing about in the last session, to your patients and to your legislatures. So we wanted to work on introducing both of these factors to our school.
So this all began at a very individualized approach. A small group of students met with 2 student affairs deans who had personal interest in sustainability to begin with. And they suggested that we meet with course directors individually and address leadership to develop individual proposals for incorporating slides and additional coursework into each one of those 9 courses, which is a bit of a doozy, as you can also imagine. And then I think the kicker was that these responses were very individualized and varied heavily on the personal interest, opinions, and perceived importance of each of those course directors, rather than the overwhelming institutional ideas.
For the elective curriculum, it was fairly easy to identify a faculty sponsor, someone who was not a medical doctor, but had a doctorate in medical ethics and felt strongly about the intersection of medical ethics and climate justice, climate ethics. And using the available resources of many of the great organizations that are represented here today, it was easy to draft an elective curriculum. However, okay, thank you. However, it took maybe a month to put the curriculum together, and then about 9 months of passing it around between different deans and getting the runaround a little bit before it was eventually accepted. And one of the main criticisms we heard was that it was too political, that this was not, a medical school was not the place for this type of education. However, that was a minority opinion, and so the majority of faculty supported and eventually approved the elective.
And so this goes a little bit into the roadblocks and responses that we did receive. We tried to compile them in a way so that we could address them, hear them, understand them, and address them. And one of the most common ones was competing priorities. Many people here know how grueling and how packed this phase 1 schedule is, and how much you have to pack in for exams, et cetera, et cetera. And so the overwhelming majority of people felt that we didn't have a lot of wiggle room in the curriculum to incorporate this. We luckily found data that was done at Emory that demonstrated that the climate health curriculum that they incorporated comprised about 0.2% of the entire curriculum. And because it fits in so naturally with the pathophysiology and with the environmental health exposures that we already discuss in the curriculum, the added connection, the explicit connection to climate change was not a large portion of time spent during lecture. Secondary was the resource constraints. A lot of people here ourselves, a lot of people in this room have felt very a disconnect between the level of enthusiasm and the level of expertise. And so often many of the professors said, this is great, but who am I to teach this? And that is where we were able to lean on, like Megan said, on these existing and publicly available resources. So that's a big thank you to places like Gucci and Healthcare Without Harm. Sorry, I'm not going to be able to pronounce it. Or remember all the letters. and the resources for health education. And then lastly, to touch on the political aspect of it, we sort of address with a lot of leadership that we are inherently as health professionals at a crossroads where we address a lot of politicized statements and a lot of politicized ideas, such as vaccines, COVID-19, reproductive health. And so I think picking and choosing where we step back and don't claim evidence-based medicine as our own lane is something that we should address and that we shouldn't shy away from. So with those responses in mind and these discussions that we had with individual course leadership, we were able to get in front of the curriculum steering committee and sort of initiate an institutional approach. Since we already knew what the hesitations were, we could kind of nip those in the bud before they were brought up. And this led ultimately to the endorsement from the committee to include climate health curriculum material in each phase 1 course, and left it to us to create the materials and distribute that to the course directors.
So we'll just skip through, but yes, again, thank you to all of these amazing groups, Medical Students for a Sustainable Future, the Project Echo we drew on lots of resources to develop, because we do not feel like experts on these issues either. And we'll kind of skip to, we have examples of the content and things we've created, but I think our conclusions are that despite not being climate health experts or having any at our medical school, the abundance of fantastic available resources allows any group of passionate students to design a solid evidence-based curriculum and implement it. Additionally, I would like to highlight, we started working on this our first year of medical school, and we're now 4th year medical students, and it's just being implemented. So having the persistence, and it can be hard if you're at a school where if you don't get started until your 2nd or 3rd year, students will cycle through, and it can be hard to, if you don't have a strong faculty support, which we unfortunately did not, it can be hard to maintain that continuity. So empowering students to jump in right from the beginning was important. And yes, the next steps, implementing the material, having representatives from our group at the lectures themselves to answer any questions and help the faculty feel supported is important, and working to recruit students for the new elective. That's where we're going from here. But I want to thank our curricular committee, other students that worked on this with us, and if anyone has any questions, happy to answer them later.
Thank you. Awesome work. So we're going to do questions together at the end. Next up is Dr. Elizabeth Cerceo. She's an associate professor and hospitalist at Cooper University Healthcare and associate program director of their internal medicine residency and a number of other titles, but let's give you your time to give us the talk. She'll be speaking about ethical conflicts in acute care. Over to you.
Thank you. Thank you so much. This talk will be in a slightly different vein. It's not a project. This is more of a thought experiment. I use this one, right? So when I started as a hospitalist, it was really for purely selfish reasons. It was because I wanted to have intellectually challenging patients, complex patients, and I wanted to have all of the resources of a tertiary care center at my fingertips. And increasingly, though, I realized that this was going to put me at odds with some of my core values, and it created this ethical quandary. So it's the paradoxical prioritization of environmentally and financially costly care of the individual over public health, and that eventual degraded public health, and of course comes back to affect the individual. And said more succinctly, it's our current healthcare system, which is de-emphasizing climate smart preventative healthcare in favor of costly tertiary care. And of course, I'm the one delivering that costly tertiary care as a hospitalist. So I believe that this sets the stage for moral injury as we're ordering our third CAT scan of the week and our 20 send out tests, and we're repeating the echo because we can't access it from Epic. We understand and we know that this is going to have downstream effects on our patients, on our ecosystem, and on our healthcare system. And I don't want to simplify everything about burnout. We know that about 63% of healthcare professionals have at least one manifestation of burnout, and it's not just from climate change, even though that's what I'm promulgating. We know that it's the EMR, it's workforce attrition, it's decreased autonomy, insurance reimbursements, multifactorial. But I do believe that one cause of moral injury is that we deliver costly tertiary care when preventative care would be better for our patients and for the planet. So in recent decades, public health has really not been seen as the purview of physicians. I think many of us can attest to this. We're supposed to stay in our lane and treat the individual. And when we venture out of that into public health, I think we're viewed with a good bit of suspicion. So why should we leave our lane? Well, all of medicine aligns itself behind the individual. Medicine gets very, very excited by shiny objects. So whenever there's a sexy new innovation that comes out, we're completely distracted. So if there's a new chemotherapeutic agent that improves life expectancy by 3 months, it's extolled as a miracle drug. There's new devices, new patents that come out, I feel like almost every day, but it's affecting maybe 1%, 2%, 3% of the population. And when we know that fossil fuel pollution causes 1 in 5 premature deaths, and of course we understand our own carbon footprint to this, we know that we have bigger fish to fry. And that's the whole system. And I would say that the whole system, the whole healthcare system is our white whale. And while it would be, I would sound very wise if I was to say that we should take a stepwise incremental approach to change, what we really need is a revolution. We need a complete change from tertiary care to primary care. We need a truly not-for-profit health system that financially benefits from healthy populations, maybe even a single payer system. I know this was alluded to earlier, a single payer system that would reap the benefit of sustainable investments, creating healthy communities that would then eventually save that single payer system money, because our health and our financial systems currently prioritize sick over health. And when they do that, how can we expect them to prioritize climate smart healthcare? So while I certainly advocate for a paradigm shift, I do understand that we have to be pragmatic. We do have to have a plan B. I say the role of hospitalist, but really this is anyone who works in a healthcare system. Often though, hospitalists are involved in academic or administrative leadership roles. We may be involved in research or QI projects. Sometimes it's just our proximity. We might be seeing patients on the 6th floor and maybe the C-suite is on the 2nd floor. There is something about hospital medicine too, I would say. It's probably 10, 15 years ago, it was very new, now not so much, but I think we still retain a little bit of that upstart firebrand mentality. A few years ago, earlier on in my career, I had written a short piece about how even when we aren't explicit about it, our work is grounded in love. Now, when I'm talking to the C-suite, when I'm talking to a CFO, I'm not going to be talking about love. I'm going to be talking about return on investment, recruitment and retention strategies. But I do think it's important as we're having these discussions to ground them foundationally in why we're doing this. It's out of love for the planet, love for our patients, our communities, the animals, and as society is increasingly prioritizing local to the global and individual whims over the greater good, what we really need is almost a spiritual transformation. So in closing, if we want to begin to take steps to heal healthcare in the US and globally, we do need to remember that our calling is based in love, not in a Pollyanna sense, but in recognition that many of the foundational problems we have in medicine, the burnout crisis, public health crises, climate crises, can all have a common solution. And that common solution is shifting our resource-intensive tertiary care focus to a climate-smart primary one, and healthcare sustainability, really broadening our circle of concern and compassion. If health systems and the US government writ large want to impact health we need to lead with climate smart preventative healthcare because it's the right thing on every level and the only thing that will truly heal. So thank you so much.
And thank you. Our next session is virtual. Are you here to help make that happen?
Yes.
Fantastic. So we're going to be hearing from two doctors who are joining us virtually today. Dr. Amelia Cussans and Dr. Eleanor Cook. They are based in London and they are climate justice advocates. So they're going to be sharing a little bit of the work that they co-lead on the Climate Health Scorecard Initiative, which supports health organizations in climate action. And I'm looking forward to hearing from them.
Thank you. Well, thanks so much for inviting us. First of all, my name's Eleanor and this is Amelia. And we're delighted to be here today, albeit online and from the other side of the Atlantic, to talk about our project or initiative, which is called the Climate and Health Scorecard Initiative. So we aim to give you a brief overview of the initiative, and then we'll be very happy to answer any questions you have at the end of the session. So I'm going to start by just talking a bit about us and our background and the background to the initiative, then talking about the aims and strategy behind the initiative, and then pass on to Amelia, who's going to talk about the domains and future directions. So Amelia and I are both medical doctors working in psychiatry in London in the UK. And we're both really passionate and interested in the intersection of climate and health. We actually met at a climate protest on the streets of London back in 2019. And we've both been involved in many kind of climate and health campaigns. One of these campaigns was to join with other colleagues and to persuade or encourage the Royal College of Psychiatrists, which is our membership body in the UK, to take all their investment funds out of fossil fuels. So we put a campaign together and this was successful. And it was kind of born from this that we were like, what else can we do to support health organizations in our country to take action on climate? So that was kind of the background. And I'm just going to take a moment to talk about why we decided to focus on health organizations. So there were various reasons for this. Firstly, because the profound impact of climate change on both physical and mental health. Secondly, because as health professionals ourselves, we felt that this sector was within our sphere of influence. Thirdly, we feel that health organizations have quite a well-respected and trusted voice, and therefore we can use this to talk to the public and to policymakers and hopefully get them to listen. Finally, we believe that change is necessary at all levels, from individual through to government, but this includes institutional change, and so hence the health organisations. So the aims of our initiative, quite simply, they were to support health organisations in climate action. We also wanted to engender kind of some transparency and enable health professionals in the UK to know what their organisations were doing on climate, or indeed actually what they were not doing as well. So in terms of strategy, we essentially created a kind of wish list, if you will, or a and we convert of actions that were achievable yet ambitious that we felt that health organizations could and should be taking. And we kind of converted this into a survey. For each kind of question, which was basically covered in action, we gave a score. And this was kind of to see where health organizations were at, basically, to compare them with other organizations, and also to enable us to, and also the organizations, to monitor progress on climate over years. The third thing we wanted to do with our initiative was to really share and encourage best practice. So what we aim to do is share case studies of positive climate action, so that other organisations can learn from them. So the questionnaire itself, this was developed by Amelia and myself alongside a working group, which included specialists in climate and finance and also climate education. And we wanted to cover different areas within the questionnaire. So briefly, because Amelia is going to talk about this in more detail in a minute, the questionnaire, the survey is split into 4 main areas or domains. These are internal operations, finance, education and training, and finally advocacy. And as I said before, we scored the answers, and the scoring was kind of decided and weighted according to what we felt would have the most impact on mitigating the climate and ecological emergency. Great, so I'm going to hand over to Amelia now. Thanks, Amelia.
Okay, thanks, Elle. So these are the 4 domains. I'll just run through them. So the first one is internal operations. And this is really us trying to find out whether these organisations have got their own house in order. So it involves things like, do they have a robust decarbonisation plan? And do they have strong leadership within their organisations to drive forward their climate strategy? We also ask questions about whether they have green procurement policies and green policies for their waste, whether they use green electricity, buildings, as well as food and travel policy. And we also want to know whether they're taking steps to make events that they're running greener. So like, for example, today, we're able to join obviously remotely, and it means much less carbon footprint from people flying in for events. So the next domain is finance, and this one is really critical. It focuses on organisations divesting their financial assets and their pension funds from fossil fuels, as well as whether they are banking with a green bank and using an insurer that does not insure fossil fuel projects. So it can kind of be easy to underestimate the impact of this, but just to illustrate it with one example, so there's a Royal College in the UK that currently banks with Barclays. That's one of the worst bank, well, it is the worst bank in Europe in terms of fossil fuel finance. And the cost of them banking with Barclays is equivalent to 4.8 thousand tonnes of carbon every year, which is also equivalent of flying from London to Rome 65 times every day for a year. So that, putting it like that, you kind of realize that it dwarfs some of their other sustainability actions. So we're calling on them to move to a greener bank. And if they did that, it would cut their carbon footprint by 75 times. So not only does moving money from fossil fuel investments obviously take the money away from being spent that way, but it also makes a social and political statement that really stigmatizes this industry. So we hope that this project will encourage more organizations to divest and move banks. The next section is education and training. We already heard from Megan and Stella about their amazing work at their university. And we're hoping that as well as having climate in the med school curriculums, it will also be in postgraduate curricula too. So that's the first question on our survey for this section. We also ask about whether they've created online learning for planetary health, whether they run conferences, whether they have fellowships, and whether they also take a role in educating patients and the public on climate. As well as promoting greener alternatives to pharmaceuticals, such as social prescribing and nature-based therapies. So this is really important to build a climate resilient healthcare sector that where the staff are able to bring sustainable practice into their own workplaces. So the next section is advocacy. There were lots of points attached to this section essentially for lobbying politicians. So we really want health organisations to advocate at a governmental level for bold climate policy and to put an end to new fossil fuel exploration. So I thought it was interesting that Indiana Med School told you guys that climate work was maybe too political. We absolutely think it's very political, that it's very essential that they do this political work, and they should be challenging the global and intergenerational inequity, as well as the colonial capitalist structure that underpins the climate crisis. So points in this section were given where it was demonstrated that climate justice was centered in their health work. This is an example from COP26, where health leaders delivered this healthy climate prescription to the policymakers at COP. This is a recent example from Royal College of Obs and Gynae and Pediatrics and Child Health, where they directly influenced legislation on air quality in the UK. And another recent example where health organisations wrote to our Prime Minister, Rishi Sunak, asking him to revoke the new licenses he had just given for oil and gas drilling. So we published our pilot in the Journal of Climate Change and Health. You can check this out. The link is on our website. Just briefly, our findings showed that the Royal College of Pediatrics and Child Health got the highest score, and the results are kind of in this league table format. We received lots of feedback that the scorecard's helpful for breaking down this really big task into manageable portions, and that it's useful for strategy. And in terms of where we're going next, we're doing the current round as we speak. So we're collecting and scoring responses. We're going to publish the results on our website. It's climatehealthscorecard.com. That's the QR code, which is coming up in the next slide too, hopefully. So we're hoping that we might be able to adapt the questionnaire for different types of health organisations, including clinical settings, and we might study the impact of the initiative in a bit more depth rather than just collecting feedback. And lastly, if anyone's listening and thinks that this work could be replicated where you are, please do get in touch with us, because we'd love to collaborate and share our resources. So thank you so much. That's the QR code for our website again. You can follow us on Twitter or drop us an email, and yeah, we'd love to hear from you.
Great. Thank you both so much. There was lots of applause before, but we were on mute, so you didn't get to hear it. So we're going to be holding, again, questions to the end, but I think we've got lots to talk about with different ways of sort of assessing what institutions are doing between medical schools, medical societies, et cetera. Our next conversation is going to be with Dr. Eva Parker. She's an assistant professor of dermatology and core faculty in the Center for Biomedical Ethics at Vanderbilt University Medical Center in Nashville, Tennessee. Holds a long list of titles, including an associate editor at the Journal of Climate Change and Health, and a lot of involvement with organized dermatology societies. And we're going to be hearing about some of that. Yes. Over to you.
Thank you so much, Caleb, for that warm introduction. I'm excited to share the results of a study that I did with colleagues on congressional voting records and skin pack donations. Oh, sorry. It is this one right here. Okay, great. I think we're ready with the slides. So I was tickled that Ed said skin in the game. Many of you may not know that Ed's father is Howard Maybach, a very famous dermatologist in California. And so I think this study is certainly skin in the game. So I want to acknowledge my amazing co-authors on this project, Max Green, Ken Katz, and Marcus Bose. Okay. So for full disclosure, I do receive honoraria as a consultant and a speaker for several companies, and I was on the planning committee for this meeting. And so I understand the baseline knowledge in this group is very high around climate impacts and health, but I do want to provide some background on this through the lens of dermatology. So first and foremost, there is a funnel effect on health impacts resulting from the pressures applied by climate change. such that our overconsumption results in ecological harm, which drives and creates the hazards that cause human health and harm human health. Things like geopolitics, systemic racism, and poverty can further amplify these effects. And these interactions are complex and multifactorial, and the result is that climate change is a threat multiplier for health, equity, and health systems. Because skin is the largest organ and the primary interface with our environment, many diseases are influenced by climate change and are climate sensitive. And that's multifactorial with complex pathophysiology. Most notably is thermoregulation, for which the skin plays a major role. Skin cancer is another. Things like vector-borne diseases and infectious diseases, autoinflammatory disorders, and their associated comorbidities, allergic diseases, nutritional deficiencies, injuries, and UV-induced disease, just to name a few. Skin also uniquely displays cutaneous manifestations of systemic disease, which are duly impacted by climate change. And importantly, too, environmental impacts, social justice, and health have key intersectionality, such that vulnerability to climate change disproportionately affects dermatologic disease in skin of color. But just like with disease, climate forces also influence health systems in multifactorial ways and subject the healthcare system to broad pressures from climate change. In particular, damage to infrastructure and accompanying economic costs from climate disasters are increasing steadily worldwide. These events hinder care delivery, they disrupt global supply chains, they devalue real estate, and they threaten institutional financial security. Extreme weather events also trigger mass population migration, which is a key issue globally due to the anticipated alteration and amplification of disease and health disparities. Consequently, health systems will be increasingly threatened in the future. Recent surveys have demonstrated that the vast majority of dermatologists are in fact concerned about climate change, and that advocacy around the critical health, equity, and care delivery implications that result from climate change is of growing importance among dermatologists. Accordingly, with these growing climate health impacts, the American Academy of Dermatology adopted a position statement on climate and health in 2018, supporting dermatology's role in mitigation efforts. And while the Academy has published over 70 position statements on topics relevant to dermatology, only a small number of these statements relate to broad public health and societal issues, and even fewer represent politically charged policy considerations that impact population health in the way that climate change does. In the US, it's commonplace for our medical societies to leverage political action committees, or PACs, to support candidates whose advocacy platforms align with legislative issues critical to dermatology, or critical to their specialty. Dermatology is really no different, honestly. The American Academy of Dermatology's advocacy mission is to specifically, quote, adapt to the shifting healthcare landscape while contributing to policies that protect the quality of dermatologic care. And SkinPAC contributions, and SkinPAC is our dermatology society's political action committee, SkinPAC contributions are identified as a key avenue to achieve this mission. And in fact, SkinPAC donated almost $1.5 million to campaigns in the 2019-2020 election cycle alone. However, prior analyses that have looked at PAC contributions have demonstrated incongruence between those contributions and the legislators' voting records with respect to society position statements, such as that of the AMAs, on important issues like gun control, tobacco, abortion. So in the context of broad impacts of climate change in dermatology, whether SkinPAC preferentially supports candidates taking pro-climate stances that align with the AAD's position statement was unknown when we approached this study. So we designed a cross-sectional study to examine those contributions from SkinPAC by climate-related voting records. We picked key legislation from the League of Conservation Voters scorecard for the 117th Congress, which just finished this past January. And interestingly, that Congress was the most gender and racially diverse Congress in US history. Bills were selected based on their alignment not only with the AAD's position statement on climate and health, but their perceived relevance to healthcare in general. Contributions from SkinPAC to federal election campaigns between 2021 and 2022 were obtained from the Federal Election Commission, and individual campaigns of members of the 117th Congress were included, while contributions to other PACs and to legislators not serving a full term were excluded. And of those receiving contributions, members' voting records for each of the bills was then obtained from the US Congress's legislative website. A vote for passage of a bill was deemed to align with the dermatology position statement on climate change. And in cases where there were multiple rounds of voting on an individual bill, we assessed the first bill or the first vote. So we selected 4 pieces of legislation to examine: the joint resolution for congressional disapproval of oil and natural gas sector nullified Clean Air Act amendments, including new rules that removed limitations on methane emissions. We also looked at Protecting America's Wilderness and Public Lands Act, which provides for conservation of public lands in multiple states and US territories. We looked at the Inflation Reduction Act, which is landmark legislation to lower energy costs, increase cleaner energy production, and reduce carbon emissions by approximately 40% by 2030. Additionally, the act provides assistance to Indigenous tribes and low-income communities to address climate change. And then the final piece of legislation was the Senate ratification of the amendment to the Montreal Protocol on substances that deplete the ozone layer. And since stratospheric ozone depletion increases UV, this is an issue really critical for skin health. So what did we find? Well, SkinPAC contributed $841,500 to 185 congressional campaigns during the 117th Congress. This table outlines those SkinPAC contributions according to the votes on the selected climate legislation that I mentioned a minute ago. And so overall, SkinPAC contributed more in total dollars to congressional members voting in favor of pro-climate legislation. And while this suggests alignment with the AAD's position statement on climate change, SkinPAC contributions to legislators voting against climate and environmental bills was also substantial, with little difference in the median and range of those contributions. As with prior studies, this analysis suggests that other legislative priorities such as reimbursement and scope of practice likely influence SkinPAC contributions far more than the AAD's position statement on climate change. However, as climate change increasingly impacts dermatology in multifactorial ways, prioritization of contributions to candidates with favorable voting records on environmental legislation really should be given. And this is what we're advocating for. And while our study has limitations, including that not all climate bills were assessed, some legislation included unrelated provisions which may have swayed legislators' votes and potentially could have resulted in an inferred stance on climate. And only one election cycle was analyzed. So it's hard to say whether the data accurately reflects historical or future trends in SkinPAC contributions with respect to climate-related legislation. It's really a capture of one session of Congress. Therefore, we are advocating that to better guide SkinPAC contributions and to more effectively and ethically advocate on behalf of dermatologists and their patients, future studies should track these contributions and whether they align with key position statements from the American Academy of Dermatology. And so to this end, we've actually submitted an updated 6-page position statement. So the prior position statement from 2018 was barely half a page. So the new 6-page position statement is now on the board of directors of the American Academy of Dermatology's desk, and they're voting on this next month. And this update assumes a much more robust stance on an accounting of climate impacts on dermatologic disease, delivery of care, and disparities. The new position statement also provides strategic opportunities to establish climate change as a legislative priority in order to fulfill the AAD's duty to patient advocacy, as well as its own stated mission to adapt to the shifting healthcare landscape while contributing to policies that protect the quality of dermatologic care. Thank you very much.
Thank you, Dr.
Thank you.
Parker. So to close out our session today, we're going to be hearing about the work of Dr. Pam Oatis and Dr. Minda Te. To give you the maximum time for your talk, I'm going to trim our introductions a little bit, but they're both pediatrician neonatologist at Nationwide Children's in Toledo, and they've done a mix of work, including CDC-funded work around lead abatement and also work focused on understanding where we're at as people as we interact with these issues. Over to you.
Well done. Thank you very much, Caleb. And I want to say thank you to Haley, Caleb, and Mark Lee for this amazing opportunity to be here with all of you and share some of our work. Minda was supposed to be here with me. Imagine a Chinese heritage Filipina, Minda Te. We are colleagues, very close, dear friends. 10 years ago, we started our creation care team together at our Catholic hospital. Her husband got very ill. Oh, look at the camera every now and then. Okay. And so she couldn't come. So you have to imagine her here because we do everything arm in arm, locally and beyond. So I am, and I advance it with this. Look at that. No, I didn't push the right button. Thank you. Well, we work with an organization called Sustaining All Life and United to End Racism. That one, thank you. And this organization, these are projects of the Reevaluation Counseling International Communities. We work on an anti-oppression basis with a deep focus listening practice that had we longer than 10 minutes together, we would do. You see here example, a picture of a group, probably at a COP or maybe a London Climate Week, where we have been for many years doing these deep listening exchanges. I am echoing what has been said by a number of people. I remember, I think it might have been Courtney's that she showed the heart of the story shared. We've heard a number of examples of the ways in which people sharing their own stories with each other move this whole process forward. I'm going to try and think about my Brazilian companions who may be at a breakout to speak more slowly so that those whose native language is not English can hear and understand what I'm saying. I'm not sure they're here. Okay. So listening exchange is the basis of our work to rid the world of oppression. And somebody has also mentioned that already, that we think and act better when we're listened to, when we have a safe, agreed upon place, a partner and or a circle to offload, to be rid of, to not be burdened and slowed down by our upsets, our discouragement, our hopelessness, our isolation, our sadness about climate, and a lot else that goes on for those of us that are healthcare providers and activists combined. As we can offload those experiences, we think better, we think more clearly, we have better ideas. It's an iterative process. Again, I think Courtney talked about that. We have an idea, we try it, we have an experience, maybe it went well, maybe it went terribly. We can come back to our listening partner who is there just to listen, not to judge, not to criticize, not to give advice. Well, why didn't you try blah, blah, blah? No, we don't need that. We need a good, strong, respectful, caring, confident in us person. I remember one of my early experiences listening to someone and I thought, oh, I should tell her something. I should tell her something. She should, and she came up with her own extraordinary idea at the end of me listening to her that I would never, ever have thought of. You are here, Elizabeth. I will slow down a little more. So these opportunities to listen and be listened to also include a confidentiality agreement so that what I say during my listening time which is not a conversation. It's not chit chat. It's focused, deep listening. I don't bring up again. I don't tell somebody else. I don't bring it back up to you unless I ask permission. We've all had that experience of telling someone something that we felt vulnerable about, but wanted to get off our chest, and hearing about it from someone else. So most of us have given up the vulnerability that Stefan mentioned this morning. That was one of the most precious moments of our day today, was Stefan's vulnerability and humanness. So we divide the time equally, in a circle or in a pair, and each person has an opportunity to speak. And tears, laughter, shaking may bubble up during that time. That's fine. We welcome all of that. We get to think through successes, talk through failures, express love and caring with a full open heart, and come up with more and more good ideas, more and more motivation, and empowering not only me, the talker, but those around me in creating circles. So we have some examples. Marshall Egenye from Lagos, Nigeria, experienced SAL and UER back in 2015. He's done tremendous work in his country. He's done teaching other people this listening exchange, building communities around him of colleagues, of students, and they have taken action. They've done listening projects in their community with these banners to find out from people what is on their minds. And this whole process of empowerment is powerful for everyone that gets involved. He's done so much that he received this Africa Climate Change Awareness Goodwill Ambassador Award, not a small accomplishment. Leonard Ababayaya from Togo heard about SAL in an experience in 2011. Two women from the US, one African-American woman and a French-speaking woman. A lot of our work we do with non-English speakers so that we provide interpretation so that they can hear in their first language. Leonard does speak English, but I encouraged these three men that I communicated with to communicate with me in French. And then I used DeepL to translate so that I got what they wanted to say in their own language. He is in Togo, and this is a quote from him that I think you've had a chance to read, his response to what it was like to be listened to and how it released him, empowered him, enabled him to do some things that he had been thinking about but hadn't actually gotten to do. They were suffering from terrible drought and famine. He spent some years training other people in the listening project, in the listening tools, and teaching them about climate change. They were not able to influence their governments, as many of us experience, although that for the Nigerians and the Togans, it really has much more to do with a violence threat than just not being able to reach their governments. But he and his group made a decision that they would plant trees. They weren't going to ask the government, they did it themselves. 250 trees in dry areas. And those trees have created forests. And we know that that changes the weather. He also worked with a gentleman from the Cameroon, and they worked with school children. So these men have also empowered children with the listening pairs and listening circles. And they made a decision as a group, again, to plant trees. Hokumito Misigbi, also in Togo, is another man who's been influenced since 2005. He's been closely involved with SAL. And again, his words are the importance it's had to him, both personally and professionally, and everything related to his life. And he's not only done a lot of planting of trees, but also a lot of maintenance, flood mitigation. So these communities that flood, they've done trash pickup and just using hand tools, handmade hose, changing where the water flows so that to mitigate flooding in their communities. So I would welcome contact from any of you. I have old-fashioned paper and business cards here. And we conduct webinars online, have done that for many years. And we are still doing that online with interpretation. So we have French, Spanish. I'm going to be sure we get Portuguese involved, German, Dutch, Japanese, Chinese, so that people have access to the information and the tools. So I welcome questions. Minda would love an email too, if anyone wants to email her. So thank you very, very much.
All righty. Thank you, Dr. Oatis. So we have about 15 minutes. Is that correct? I think we're reapproaching back on schedule. So I think we can actually get into this a little bit. And I would love to hear from folks in the audience on what you're thinking, what you're wondering from our panel, having heard all of these talks. We'll start with you.
Thanks so much. I hope you can hear me. Thank you everyone for those very interesting presentations here and online as well. I had a question for Megan Eigsti instead of the professor. Totally good. Congratulations on your great achievements. I think it's really commendable what you've achieved across many years, and exciting as well. I think around the world we see that most of climate change integration into the medical curriculum is actually done and initiated by students. So I'm wondering what's next. How do we incorporate this in education across this country? And what is the role of your success and the role maybe of success of medical students globally in achieving such things?
I'll try to be louder, sorry. Those are very big questions, very good questions. And I think, I don't know, I can speak for Stella, but the US medical system is very decentralized and not, we have the AAMC, but I am not sure what their role in driving individual curricular efforts are. However, I do think advocacy at that level, perhaps introducing new, I know Canada has much more robust educational standards around incorporating social determinants of health and advocacy, like the physician's role as an advocate within their priorities that are set out, and the medical schools to be accredited have to comply with. And so I think doing something like that, which would take more advocacy at the national level, would be a good step towards doing that.
I can also add briefly to add to what Megan was saying. One of the deans told us our goal sometimes at the medical school is not to be at the head of head of the pack and not to be the last ones, but to be in the middle. And so that a lot of problems have already been ironed out. And then there's wider and wider and faster adopting, which is a sad statement, but it's not an untrue statement. And so that is why we are thankful for a lot of schools and a lot of resources. There also at the national level will be climate change breakout groups for, I believe, the first time at the AAMC coming up. And then I think something that Megan touched on in the presentation was this sort of spaced repetition within the preclinical years, so that when our trainees go out into the community and later become educators, this is something that is a little bit more of a ingrained and established thing. I think all of that to say that's why here we come kind of thing.
Great, thank you. Other questions from the audience? Yeah.
I just have some additional commentary related to recent actions by the AMC, which is that they joined the National Academy of Health Action Collaborative and decarbonizing health sector, and then also they just started a climate action and sustainability in academic medicine. So it appears to me that their focus, at least their first focus is, and I don't speak for them, but it appears to me that their first focus is on healthcare delivery and sustainability, and hopefully they will eventually also try to support all of these efforts in climate change and patient health.
Anybody want to comment on that before we move to the next question? Yeah.
So one thing that we're doing within our medical school is creating those medical education program objectives. We've done this for racism in medicine, now for climate health, so that it's not national, but within the microcosm of your school, you can develop a tracking system where you can map out all the curricular elements. You can see where it tracks in each lecture and then update that content because it's so rapidly changing. So sometimes MIPOs can be helpful in mental education program objective.
And I would like to actually hold out to those of us that are faculty and or alumni, that it's a place that we could back medical students, so that they're not having to do it alone. Not that we would do it alone for them, but that we could form partnerships.
Thank you. Yeah.
Hi, another question for Megan and Stella. I'm also a medical student and I'm at Mount Sinai, and we incorporated climate change content into our curriculum a couple of years ago. My question for you is, do you have any sort of mechanism in place to make sure that the content you're incorporating gets tested? Because the problem that we had is that many faculty will sort of read the slide and then it doesn't make it onto the exam. And I think there needs to be institutional recognition that this content is important and has to be tested. And a related question, does anyone know whether climate change content is on boards exams or how we might go about making that happen?
Yeah, so we had the same exact discussion because we said a lot of the material that isn't directly tested is perceived as fluff material for a lot of students, unfortunately. And I think that's part of the reason that the CRHE is developing these test questions in order to incorporate that. And the USMLE has now increased the percentage of tested questions regarding more social determinants of health. We actually discussed approaching some of the, we are fortunate to have access to some professors who do participate on USMLE test question development and review. And I think that's an excellent avenue to address to demonstrate how important this is, because you're exactly right.
Great. Other questions from the audience? I have a couple of thoughts. Yeah.
So my question focuses on language, and what I sensed and heard from pretty much every single speaker was some relationship between climate as an environmental issue or a planetary health issue, but not in all circumstances the only one that is relevant to health professionals or to people in general. So an anecdote to share is from a local climate debate that a conservative person running for the seat did show up to, and that individual shared that to him and to people of his political tendencies, climate was a no-go zone, but conservation was something that he profoundly cared about. And so a planetary health report card, I'm just curious in that specific instance, but also to any of the speakers about in your daily life, in your advocacy work, in your clinical work, if you feel like climate is the main area you want to go, or do you feel like in this historical moment with the 6 mass extinction, with COVID as probably a zoonotic disease, with antimicrobial resistance, and with a triple planetary crisis of climate, pollution, and biodiversity loss, if we could possibly push ourselves to go beyond talking about climate as if it were the only environmental issue.
The microphone is closed, so I'm going to respond quickly and then pass it on. I agree with you that we want to stay away from red flag in front of the bull. And I go back to the Braver Angel presentation. I've gone to their Zooms. I did one on a car ride. Finding common ground. No one wants children to die. I'm a pediatrician. It's a really good place to start. And finding common ground, not lecturing at people, but where's our common ground? And maybe the polar bear, okay, polar bear's better than nothing. We like to see the child with asthma maybe, but I agree with you that common ground, being together in teams of everyone, my Trump neighbor down the street and I, going toward something where we all survive is where I'm headed. I'm right with you.
Thank you for that. So a lot of times when I'm seeing patients in the hospital, I have the benefit of letting them talk first. So I'll get a sense of where they are, and then I'll try to meet my language to where they are. And just as you were talking about language of conservation, if I talk about air pollution and how it impacts their asthma and their COPD, that's going to be met with a lot more acceptance than if I talk about greenhouse gas emissions or something like that. So I'll try to tailor what I'm saying to them. And I think if they feel heard, then they might be more open to some of the conversations later, maybe not even on the first day. There has to be some relationship building with that too, which I know you don't always have a chance to do, but.
Yeah, thank you. I totally agree. And as a dermatologist, things like UV and air pollution, which have both increased because of human activity, are something that I see manifestations of every day in my clinic. And so I have a broader conversation with patients about environmental impacts. And just to bring it back to the study that we did, that was partly why we didn't just focus only on climate legislation. We also looked at legislation that impacted UV and also impacted conservation of public lands, and biodiversity law should concern us all because of what you mentioned. Many of our medicines are derived from plants. When those plants go away, we may not have new therapies to treat things like multi-drug resistant bacteria, and certainly emerging infectious diseases are absolutely linked not only with climate change, but with deforestation, urbanization, and globalization.
I think that we focus most of our conversation on environment, on built environment and natural environment. And I think that's the terminology that we sort of chose to focus on. I do think that there is something to be said for minimizing the terminology. So we found a lot of, when we moved planetary health, we found we were faced with a lot of blank stares because that's not a term that is as broadly utilized. And I think that there is something, we are obviously a group of people who spend a lot of time in this arena and have heard a lot of terminology and are familiar with this. And I think the more inclusive that our terminology can be, the better off we are, and the more different viewpoints we can incorporate.
Great. What's up? Yeah. Amelia, do you want to comment on that as well?
Sure. All I would really add is that there is some evidence now that the term climate change is a bit soft. It doesn't really make people realize the kind of scope of the problem, which is why we try to talk about the climate crisis. But also, yeah, I agree with the point of the original question that obviously that doesn't encompass the biodiversity crisis very well. And ideally, we would say the climate and ecological emergency every time, but sometimes just for simplicity and to kind of avoid jargon, really, we just say climate.